So up next is my privilege to introduce Dr. Kimlin Tam Ashing. She's a professor at the Beckman Research Institute at City of Hope, Deputy Director of City of Hope's Division of Health Equities, and Founding Director of the Center of Community Alliance for Research and Education, CCARE, at City of Hope. As an advocate scientist, Dr. Ashing is advancing population health science in practice. She's a population behavioral scientist working closely with multi-ethnic and multisectoral partners to develop and implement evidence-based, culturally, clinically, and community responsive health improvement studies and intervention. And I'd like to add that I've actually worked with Dr. Ashing for the last 15 years, and she's been a wonderful mentor and leader. So please welcome Dr. Ashing.
Welcome. Good morning. So I should just go ahead and start sharing? Okay. So I am totally delighted to be a part of this amazing set of workshops and presentations with a focus on survivorship and quality care. So I titled my talk, Embracing Shades of Survivorship, Culture and Context. Next slide, please. Or should I try to take over and try to share my? So City of Hope was founded over a century ago, really to care for the medically underserved. We are a NCI designated comprehensive cancer center, and we have 31 community practice sites throughout our 4 counties, Los Angeles, Orange, Riverside, and San Bernardino. We treat all forms of cancer, as well as diabetes and actually other chronic diseases as well. And CCARE, which I started, and Myra has been my right-hand girl from almost the very start, in 2008 in response to health disparities. Our mission and work are to engage multi-ethnic community partners, diverse and multisectoral community partners to increase healthy lifestyle, cancer screening, access to care, clinical studies, and all of this to improve community well-being and health equity. So can't talk about health or life in general without having some discussion about the COVID-19 pandemic. And wanted to quote our leader, our civil rights leader, Dr. Martin Luther King: of all forms of inequality, injustice in the healthcare system is the most shocking and inhumane. And COVID-19, even if we try to pretend that all is well and we didn't have health disparities, well, COVID-19 really punctuated that for us, with Native American, Latinx, and Black population dying at twice the rate of whites. And in the initial rollout of the vaccine, we saw huge disparities in terms of where the vaccine was being rolled out, with Blacks and Latinx having lower rate of vaccine availability, as well as even testing. And City of Hope has taken action in this space. And we work diligently with our community partners, and CCARE led a lot of the work with extending our reach to increase vaccination among our medically underserved and vulnerable populations. Next slide. So the objectives are to increase knowledge of cancer burden among ethnic minorities, to talk about societal determinants of health and the top cancers, and then spend most of the time, I hope, in having some discussion about survivorship and the challenges in both research and practice, considering multi-level factors, including systemic, provider, investigator, as well as patient-level factors. Next slide. So cancer screening, next slide. So these are just topics so that we know we're shifting. So what we see here is very low rates of colorectal cancer screening, a bit better with cervical, and looking at breast cancer, we are not doing as well in terms of what we need to do in screening. We see that African Americans seemingly have comparable rates of screening and even slightly higher rates in terms of cervical cancer, but still having greater mortality. So some of the challenges with screening data is much of it can be self-report. So you're getting a bias in terms of the self-report, but also sometimes we're not asked about repeat screening. And we know for all of these cancers, there ought to be repeat screening. And so asking a person if they've ever had does not quite capture. Next slide. So I wanted to talk again about the decline in cancer screening due to COVID-19. And we see colorectal cancer going way, way down in the middle of last year. And we are working diligently with ACS and other partners to increase screening, focus on colorectal, cervical, breast, but also lung cancer screening as well. Next slide. So wanted to show this slide in terms of cancer deaths. So talking about sort of incidence of mortality. And the reason I wanted to highlight this is oftentimes we are not addressing the needs of all of our ethnic groups. And here we show, unfortunately, the persistent disparities in terms of Black death, but also in terms of if you see the Asian and Hispanic population for these GI cancers are comparable. So those populations need to be attended to in terms of access to better screening, access to earlier diagnosis and quality care to improve the lives of all of our ethnic minority groups, including our Asian and Latinx population, and especially in terms of GI cancers. Next one. The next slide, this is just a topic. So again, overall, in terms of cancer death, we see African-American, unfortunately, leading. So the death rate is almost 178 per 100,000. Whites have also a fairly high rate. Asian and Pacific Islander have a lower rate, but again, we need to look at subpopulations. So even though I'm presenting this and it's a Pan-Asian, we need to look at subpopulation. And of course, the American Indian, Native American population have fairly high rates of cancer mortality as well. Next slide. So this is just showing for male and female in terms of cancer incidence. And here we see, unfortunately, African Americans, again, leading with 515 per 100,000 for Black men. White women have higher rates of cancer incidence, followed by Black women and Hispanic, Asian Pacific Islander, and American Indian population. Next slide. In this slide, I wanted to show both the incidence and mortality for men and women for the top 4 cancers. And unfortunately, again, really wanted to highlight the disparity that we see for our Black African-American population with higher incidence for prostate cancer, colon cancer, lung cancer, and that's true for Black men and Black women. Unfortunately, prostate cancer leads overall across all cancers, leads in terms of disparities for cancer incidence and mortality across all cancers. Prostate cancer shows the worst health disparities for across all cancers. And unfortunately, that's borne by Black men. And across all cancers, Black women bear greater mortality. Next slide, please. So I wanted to show this because this captures our local population and looking across the 4 counties, Los Angeles, Orange, Riverside, and San Bernardino. You'll have this, I know I'm going through this quickly because I want to get to the survivorship piece, but you will have access to these slides. And it shows that, you know, and the reason I want to contrast this is that we see ethnic disparities across all communities. When we look at place, so we look at across these counties, they're not too much differences. So in terms of regional variations, we don't see a whole lot of difference in terms of, you know, cancer incidence and mortality, even from men and women. But when we look across ethnicity, that's where we see the disparities. Next slide, please. I want to shift now and talk about the societal determinants. And I really want to target this because here is an opportunity for action. And I titled this, you know, shared action, because we have a shared responsibility in all of this. So societal determinants are conditions where people live, work, play, worship, eat, learn. These are increasingly documented as the root cause of our health status, our health risk, and our health outcomes. Laws, policies, and practices, both historic and current, maintain these inequities, and they have dire health consequences and legacies. So when it comes to your health, your zip code may be more important than your genetic code. And we have such a diversity. And so these images that I have here present images in terms of, you know, ethnic diversity, income and job disparities and diversity, pollution, where we live, you know, and access to healthcare, access to quality food, depends on our zip code and certainly impacts our quality of life. Next slide, please. So this slide just shows basically some of what I was saying before, looking at social inequities, issues of class, race, ethnicity, immigration status, gender, of course, and sexual orientation. These inequities also stem from institutional inequities in terms of, you know, governmental policies and regulations, you know, access to quality healthcare, quality food, you know, healthy environment and living situation, how we use land, do we have green space, what kind of transportation, housing has been a major issue for us in California, and it's just getting worse. And I keep saying, you know, how is it when you spend, you know, 80, 90% of your salary and income on housing, and then just a little bit left for food and transportation, which is important in terms of getting to work. You know, where is the money going to come from in terms of healthcare and the prioritization? So definitely employment, income. We look at, you know, social and environmental issues related to culture, related to class issues, racism, gender inequities, and it's certainly access to social services that vary depending on where you live, and access to healthcare, education, critically important for our minoritized communities. And these factors certainly affect your behavior, right? So we did a study looking at density of dedicated tobacco vape shops. And in the Antelope Valley area, in areas where there is higher ethnic density and higher poverty, there's greater density of dedicated and tobacco vape shops. And that means that these communities have greater access to these carcinogens. And in fact, it's also a little bit cheaper in some of these communities. So huge injustices in terms of targeting those communities for things like alcohol and tobacco products. And if you have easier access, of course, you'll have higher rates of smoking. Where there is, food deserts and lack of healthy, low-cost foods, you're going to have poor nutrition, poor physical activity if there's not safe parks and recreation, so that it increases your risk. Those affect disease risk and outcomes, and certainly mortality. Next slide, please. So I wanted to present this on redlining. So this was in the 1930s. The Home Loan Corporation was actually a federally instituted entity, and they decided which communities were to be slated for degradation and deprivation, and the communities that were being assigned, A+ status, meaning that these communities were more affluent, more white, and the communities that were slated for degradation were immigrant population, especially African-American, Black population, and Latinx populations. Next slide, please. So I know this is a very busy slide, but what it shows is parts of LA County that's in the red zone. So if you can see this on your screen, you're seeing Compton, very red, and all of that South Los Angeles area in the red. And the green areas are, those areas like Santa Monica, Burbank, some parts of Pasadena, but some parts of Pasadena not. So you have these communities that were slated for home loans improvement, economic education, healthcare development, and those in the red zone for deprivation. And what we see is that those societal factors clearly impact health outcomes. So on the right-hand side, you're looking at health outcomes and how these have changed over time. And you see very, very little change in terms of movement towards higher income, healthier communities, and the communities that were designated for deprivation still continue to experience huge health disparities with very little change or movement over time in these communities. Now, we are seeing gentrification, so that is changing more recently, but these concerns within how these communities were slated for degradation persist even today. Next slide, please. So the human cost of health inequities. Ethnic minority and low socioeconomic status person bear unequal burden of cancer and other chronic disease, receive inadequate preventive care and screening and delayed diagnosis and treatment and poor quality care, receive care primarily in community settings that are burdened and under-resourced. And studies show that 34% of cancer deaths among all US adults could be prevented if socioeconomic disparities were eliminated. Unfortunately, low socioeconomic and ethnic minorities are underrepresented in research, including clinical studies, are understudied in research, including clinical studies. And you may be wondering why I designated those, because they're underrepresented even in studies that are open for diverse populations. Most studies don't meet the targets for ethnic minority, and few studies focus on issues that are critical to our community. So we're not included in the general studies, and we're not targeted for studies that address disparities in cancer. We do not rapidly benefit from medical advancements. Health education and advocacy focused on ethnic minority populations are lagging. And so in the clinical studies, we see only 38% are women, 68% are white European, only 15% Asian American, 4% Black, and 4% Hispanic, Now, the Hispanic population is 20% of the US population. So this statistic is egregious. Next slide, please. And I know this is a fairly dated slide, and we're looking to get more updated data. But what I wanted to show in this is the mortality for breast cancer in Los Angeles County. And so we have a county rich in diversity, but have huge socioeconomic disparities. And so when this study looked at this data about death comparing Blacks and whites for breast cancer, Black women had a 71% chance of dying within 5 years compared to their white counterparts. So I hope as we look to find more updated data on this study, that we will see that this disparities that seem to be on the trajectory for increasing, and I hope that that's not the case. So, but wanted to present this because this really focuses on our local data and the Black-white disparities that we see that was actually widening. Next slide, please. So this is moving into my data and looking at studies that I've done over the years with my team. And so the type of surgery, we found disparities in breast conserving surgery for our ethnic minority population, and less reconstruction for those who receive mastectomy, with African Americans and Latinas faring worse in terms of breast conservation, but also receiving reconstruction after mastectomy. Next slide. We also found, unfortunately, diagnostic and therapeutic care delay by ethnicity. And this is a data set of several hundred breast cancer survivors within a multi-ethnic cohort. So these were women who were diagnosed with breast cancer, not metastatic breast cancer. And we looked at several factors related to their outcomes and found that African American had higher rates of therapeutic care delay, and Latinas reported higher diagnostic care delay. Next slide, please. So we also looked at lifestyle changes. And we know that this is so important to survivorship, and cancer diagnosis really is an opportunity and a punctuation in most people's lives. And many respond with the opportunity to examine issues around lifestyle and stress management as a way of coping and improving quality of life and length of life post-cancer. So we asked those questions, and across the multi-ethnic cohort. So the good news is almost 60% across the ethnic groups said that they're making healthy lifestyle changes, less so in terms of exercise. And this was across all groups, but especially among our African American and Latino sisters. They were not increasing in exercise. Asian Americans seem to report more increase in physical activity. Use of complementary and alternative medicine, about 30%. But Asian Americans reporting that they're incorporating those more so than African American and Latino population. And similarly with stress management, Latinos only about 30% reported, stress management, stress reduction, only about 40% of African Americans. So we have our work cut out for us in terms of, psychosocial oncology and supportive care medicine in helping our, cancer survivors increase in terms of healthy lifestyle and also stress management. Next slide. So in terms of social support, I was always and continue to be very surprised when we looked at this data showing actually Latinas and our Asian sisters reporting lower social support. And we thought that in these communities, probably because of, gender role socialization, that these women were being expected to continue to care for the family, even in the face of their breast cancer. And, we know that many people look fairly good, even after treatment, seem to be doing well, and not wanting to burden the family, not wanting to tell the family they need, help and support, are being, pressed upon to still continue taking care of the family and therefore report lower, social support. Next slide, please. So overall health-related quality of life for our multi-ethnic cohort, and we wanted to look at the interaction between income and ethnicity, and found that if you look at the European slide, that income is beneficial in the sense that higher income shows increase in quality of life. So a higher number is a better outcome. African Americans, only at the very high income rate, we see, an improvement for quality of life, and for our Latinas as well. For Asians, we see sort of a mixed presentation. So income is certainly critically important to quality of life, meaning they probably have access to better healthcare services, better supportive care, better continuity of care. So definitely the issue of financial toxicity is impacting our lower income women more gravely. Next slide, please. And this is showing the overall health-related quality of life by the sub domains. So overall, for the global quality of life, we see actually African American reporting similarly across, compared to our white population and our Asian population, but overall quality of life was a bit lower for our Latinas. For physical functioning, we saw our Asian sisters doing a bit better. And again, unfortunately, our Latinas faring worse in terms of physical functioning post breast cancer. Family and social well-being, again, Latinas had reported poor outcomes, and similarly for emotional and functional well-being. So our Latinas seem to be having a greater impact due to their breast cancer, and should be identified as a population for addressing the unmet need, addressing family engagement and inclusion in supportive care. And when we look at overall health perceptions, though, our Latinas are, doing, fairly okay compared to our white population, and our African American and Latino African American and Asian population having reported a little bit lower overall general health perception. And the general health perception seemed to tap into sort of a future orientation of how you think, things will be in the future. And so this may be representing a sense of hopefulness for Latinas. So even though they're reporting poorer overall quality of life and physical functioning, family, emotional, and functional well-being, seem to be presenting with a bit more hope in terms of, future. So their general health perception is not showing the decline that one would expect given some of the other, assessments in the other domains. So next slide, please. So overall quality of life by ethnicity. African Americans and European Americans report more favorable emotional well-being compared to Latinas. African American Latinas reports a bit lower physical and functional well-being. Latinas endure greater distress and depression. Aggregated data for Asians show disaggregated data. So the one I presented earlier showed, sort of the Pan-Asian, but when we disaggregated the group, we saw actually lower quality of life for Korean Americans and Southeast Asian and Pacific Islanders. And these scores were comparable to the Latina scores that I showed earlier. And so these sub-Asian groups did a little bit worse than, say, the Chinese and Japanese group. So ethnic minorities also report greater spiritual reliance in coping, and ethnic minorities suffer greater sociological and financial burdens. Next slide, please. So overall quality of life and cultural relevance, and these slides sort of pop in as graphics, so you could just keep clicking so they will show in. So although health-related quality of life is a multidimensional construct, what my work and others have done is say that it's not just the cancer and it's not just the medical treatment, although that's critically important, but we need to look at systemic factors. We need to look at quality of care. We need to look at pre-morbid factors. What was life like before the cancer? What was some of the environmental factors related? And so that these can be considered distal variables, but still critically important to quality of life outcomes. And if we, chose to, of course, the medical factors would be the more proximal, and that's what's being measured, but we're saying we need to measure the sociological context as well. Next slide, please. So this is the model I wanted to share with you, especially for those, advocates and researchers. So we want to measure sociological context, broad demographic context, and sociocultural context that would impact, psychological well-being, medical factors, quality care, and the relationship with the doctors. So what's your communication with the provider? What's your sense of ascribing trustworthiness, and so that you would be adherent to the medical treatments? Next slide, please. So some of these contextual determinants are just, core priority factors for us to measure. We also want to look at the societal determinants, some of the determinants that I mentioned earlier in terms of education, work, neighborhood level factors. And actually, even though in sociology and anthropology, contextual factors have been looked at, we haven't done a good job in terms of psycho-oncology and supportive care in terms of looking at these important neighborhood level factors. And addressing and understanding these multi-level factors would be critically important to eliminating health disparities and achieving health equity. Next slide. So we know that most cancer survivors are living longer, that it's expected to reach, well over, 20 million. And ethnic minorities are increasing our representation among the general population. And we're going to be increasing among the cancer population as well. And so we need to attend to the diversity of the cancer survivor population. Our studies need to target our community and look at the issues that are burdened to specific groups in terms of not just cancer side, but some of the quality of life and post-cancer treatment issues that many of our communities face. Next slide, please. So this would focus now a bit on the Commission on Cancer and the IOM report recommendation for the survivorship care plan. And I know various institutions have, done some in attempting to provide, survivors with survivorship care plan. And some of the regulations have been, reduced because these are hard to, be billed for and all of that. And we know healthcare is all about finance and profits. So anyway, but certain, organizations are trying to implement this. And in our group, we really try to develop, culturally tailored survivorship care plan templates for our, that's more patient-centered for our patients to use. So certainly medical vulnerabilities include premature, all-cause, but also cancer-related deaths. Cancer survivors also have a risk of reoccurrence and second cancers. It disrupts endocrine function and issues. Certainly there's menopause, reproductive and sexual health issues. It affects the skeletal muscular system, heart, bone, even dental problems, and certainly the lymphatic system with lymphedema that breast cancer survivors especially, but also cervical and GYN cancers experience lymphedema of the lower extremities. And, psychological and psychosocial problems in terms of anxiety, fear of cancer reoccurrence, and psychosocial strain, as we saw with some of our communities reporting, lower family functioning and social well-being. Next slide, please. So when treatment ends, it's recommended, and I think actually as treatment is, proceeding, that patients should be provided with a treatment summary and survivorship care plan. And that should be a living document that's modified and updated. And certainly with telemedicine and electronic delivery, this can happen quite easily. But a treatment summary, a surveillance and follow-up care plan that lists all of the providers that you need to see, including specialists, and this would depend on your cancer, on your overall health status, your comorbidity, your age, your gender. Although much of this, in examples that what I would give actually is focusing on breast cancers, but the follow-up care would depend on all of these factors. It should also give health advisories for nutrition and physical activity and stress management. It should give quality of life information and community resources. Next slide. So it's expected to increase survivorship and survivorship well-being. With a survivorship care plan, it's expected to increase your knowledge. It also should increase the knowledge of all of your treatments, not only for your oncology care team, but also your general practitioners. So this survivorship care plan is a document that should be shared with all of your providers, including your primary care provider. And I would say your dentist, your vision care specialist. So everyone knows, the side effects of your treatment and the fact that that their treatment may have an interaction with the cancer. And so I think it's important for survivors to have this document so that they can share it, because it's not always that the healthcare system is integrated enough to have this information shared across your providers. It should help improve communication because you have the information in front of you. It's hopefully going to improve quality of life, access to resources. And, the word is still out whether, survivorship care plans are actually doing this. My thinking is that patients are actually not getting comprehensive survivorship care plans. So it's difficult to measure the impact when patients are actually not having access to it. Next slide, please. So this goes into the care plan template, sort of based on the IM and the Commission on Cancer. We developed this template for breast cancer survivors. It's multi-ethnic, culturally responsive. It's a bit word dense, but we wanted to make it important and relevant in terms of, packing in the information for the survivors. So this first page is one that is tailored to younger survivors. Next slide, please. So this other one is tailored to African-American breast cancer survivors. and it gives the same kind of information, what you need to know, after diagnosis, what the survivorship care plan should look like in terms of the documents, and what it should contain. The health history, and we thought it was important to include your overall health history, not just your cancer history, so that you have an integrated document about your health status. Next slide, please. So we also developed this for Latinas. And one of the important things that we decided with input from the community is that for language minority population in the healthcare setting, it might be important to have documents that are bilingual and not just in language. Because when we have documents in language, yes, it could be patient-centered and important for the patient to use, but there's always an interaction with your provider and your clinician. And we thought it actually would be more empowering actually for both the provider and the patient to have documents that are bilingual. Yes, it's more text dense, but this way there could be some level of communication between the provider and the patient, even when the provider does not speak the language. So again, this goes through all of the domains for the survivorship care plan. Next slide, please. And you see it has general information about the patient. It has cancer-related information. You see here it has, diagnosis, your surgery, path report, staging, hormonal status. So we are advocating with this, and that it's important to get precision medicine. So you should have genetic testing and genetic counseling, so that the histology of the cancer, so that you can get treatment that is tailored and targeted to your treatment. We also know that ethnic minority and lower socioeconomic persons are not getting access to these. So these tests are becoming cheaper and more widely available. So if you haven't had one, even if after your treatment, you can still have your germline, because they usually have tissue. You could have that tested. You could also do, blood testing to get, sort of genetic components of the cancer. But that would help you determine whether you have a greater family risk, and whether your family, your first degree relative, should also get tested or screened earlier for cancers. Next slide, please. So this just goes in again, showing you more information about the cancer and treatments. Next slide. And more on your overall health, because we want this integrated into all of the providers that you see. So this is very in-depth, and we think that is best for our patients. We also advocate that patients could send this to the provider so that they can start completing it ahead of time, so you're not being billed for an extra visit during that time, and then they can have this ready for you at your next appointed schedule visit, and then have a discussion about this. We thought it was also important to include all of the chronic illnesses, as well as the medications that you're on, so that all of your providers can be alert and aware of any kind of medical interaction and vulnerability. Next slide.
Hi, Dr. Ashing. It's Myra. Sorry to interrupt. Just giving you a 1-minute warning and
1-minute warning.
Session.
So just go through quickly, Myra. We could go through the end, or whoever's managing the slide. And it should also give you resources. So survivorship inequities, lots of studies, very little inclusion of ethnic minority population. Next slide. So in terms of culture and context and really personalizing cancer care. It's important that we care for our most vulnerable, that we have culturally and patient responsive care, that we identify patients who are maybe at higher risk for reoccurrence and therefore having better and more frequent surveillance. Again, genetic counseling and genetic and genomic testing that can inform targeted therapies and personalized therapies. Immunotherapy took a long time to hit the road as part of our care, but it's increasing now. And that should be available for our medically vulnerable and underserved population. Next slide, please. And we need to create multi-ethnic, multisectoral network of care. We need to build resources that address cancer care, chronic disease care, medical issues, financial, housing, transportation, family well-being. It needs to be integrated care, addressing the whole person and addressing nutrition, emotional well-being, spiritual well-being. We need to develop effective communication and facilitate patient activation in their care. We need to consider other kinds of vulnerabilities, including substance use and abuse, including even early childhood abuse, as well as domestic violence. We need to address access and cost of healthcare. City of Hope is leading a charge with many community partners. The initiative is called Cancer Care is Different, because we know that the Affordable Health Care Act has been wonderful for increasing care for those who were medically underserved. But when it comes to specialty care, like oncology care, that's where we have lots of challenges with patients, reaching specialty care and good oncology care. And I think that's why we saw delayed in diagnostic care and delay in therapeutic care for our ethnic minority population. And certainly we need to integrate, genetic counseling and nutrition, address, geographically vulnerable areas, as well as, ethnic minority population. We need to have integration into primary care and better training across our healthcare team. So we need greater diversity of our medical care providers, as well as our researchers, so that ethnic minority issues could be front and center, so that we could be better prepared to address health inequities and to achieve health equity. So the next slide, I don't know if we could run through these quickly. The next slide. So these are some of the facilitators and barriers of inclusion, especially inclusion in clinical studies. And I really believe that clinical studies are part of good quality care. And if you have a cancer diagnosis, your healthcare team should be having a discussion with you about clinical trials, at least educating you about where you can look for clinical studies to see if you can find one that's available for you. And the facilitators of access to care, honestly, are the same facilitators to clinical studies. It has to do with provider recommendation, cost issues, coverage for healthcare, transportation, having a diverse team that really is culturally responsive and culturally and linguistically responsive to talk to the patients, to gain their trust, to say yes to participate in clinical studies. And again, we need more diversity in terms of our practitioners and our researchers. So I thank you and want to leave time for discussion.
Thank you so much, Dr. Ashing, for all that amazing research and work. I'm lucky to have the privilege to do some of that work with you. So we're going to go with our first question. And the first question asks, you mentioned neighborhood factors as having an effect on cancer. Can you expand on what's included in neighborhood factors?
And so these are broad. So these could be environmental So if you live next to a freeway or, toxic chemical recycling or collection plant, all of these factors are, certainly environmental, but also we look at the social environment. What are the services that are available in your community in terms of, do you have healthcare setting that is close and well resourced in your community? Do you have high level of density of dedicated tobacco vape shops? So like at every stoplight, there's a tobacco shop or a liquor store. Environment also involves whether you have access to farmers market or a grocery store that has fresh fruits and vegetables at reasonable cost, and you're not going to the corner store that's a convenience store where, even if they have fruits and vegetables, the quality is really bad and the cost is really high. Your school environment, we know that education is related to income is related to access to care, income is related to coverage and insurance. So it's multi-systemic factors that are included in the neighborhood. And, I could provide this slide that could be put on the website later on, but Myra did this wonderful work where she looked at the redlining and how that affects communities today. So even today, those communities that were redlined have poorer health status, asthma, obesity, diabetes, life expectancy is lower. So these communities still continue to suffer because they have not caught up. And these communities also continue to show degradation because they're also not being given the loans and the resources and the economic development that goes with job and income. So these communities also continue to suffer on multiple levels, including health outcomes.
Right, something as simple as just qualifying for a home loan, right? Because home ownership builds generational wealth. And so it's what allows us, for children to go to college and, address all of those other factors that you mentioned. So it is something that we usually don't think about, but definitely has an impact on our health. Now, our next question, Dr. Ashing, is how do you know that genetic testing will be kept private and not used in a discriminatory manner?
Personal data is something that we are concerned about, and we ought to be. And so many entities are tracking us, right? I thought like when you do a Google search and you type in a keyword that everybody gets the same response, but it doesn't. It depends on what you searched before. So you get a very different response. We found out that Uber gives different prices for the same location, right? So my daughter and I were in the same place. I use Uber a lot when I travel. She hardly did. And for the same distance, she was quoted half the price because she doesn't use it that much. They're trying to encourage her to use it. That said, data is being collected all over the place. I have had several genetic testing. I personally don't have cancer, but I have a strong family history of cancer, both my parents. I have a niece. My brother just passed away with bladder cancer. I have a brother with prostate cancer. So I want to know what's my genetic vulnerability. I just recently did one a few months ago. I did one like 2 years ago because they're getting better and they're getting less expensive. And actually, if you're a City of Hope patient, so I get my screening and my testing at City of Hope. If you're a City of Hope patient, you get your full genomic testing. Actually, it's done free for all patients. So I need to do it for me. So it's a personal decision because I want to know. And if there's anything preventative or prophylactic that I could do in terms of what my genetic information is giving me, I want to be able to do that. So I I believe that we're getting better about patient data safety, and protecting those data. But of course, we cannot completely guarantee this. But for me, it's important because I have such a strong family history that I want to know. Unfortunately, because the data that these genetic tests and mutations are based on are mostly white. Ethnic minorities, unless you have one of those prominent, like the BRCA mutations, often get mutations that could be problematic, but of unknown significance. So I get about 4 of those that look suspicious, but they really don't know because the sample has not included enough ethnic minorities to see if those mutations really are driving certain types of cancers. It's suspicious, but it's not known because it's not, one of the common ones. So I would encourage you, if you, talk to your family, if you have a family history that suggests you have some vulnerability, I think it's worth having that knowledge that you could take action, to protect your health.
Yeah. Yes, anything we can do to be able to reduce our risks, right, and protect our health. Now, our next question says, can we access the usable CCARE? I'm assuming they mean treatment summary and survivorship care plan, even if we're not treated at City of Hope.
Yes, definitely. So we could make it available to the cancer support community. We have one that's English and Spanish, but these are tailored to breast cancer patients. We could give you a template that you could modify. We have a general one that's available in Korean. So again, it's always bilingual. And that one is generic, but it's briefer. It's not as detailed as the one that we created for breast cancer survivors that's really advocating, full patient engagement and full patient knowledge.
Yes, thank you. Our next question is, how has value-based healthcare been advancing to address racial cancer disparities?
It can be a mixed sort of blessing, because for some, value-based care is really looking at cost. So through the lens of sort of reducing cost, how many patients can you see for, this amount? I think we need to rethink our whole healthcare system as a whole, and it's so complex. And we saw the struggle to pass the Affordable Care Act for everyone to have the right to healthcare. So it's a very complex societal issue. I think we need to have human-based healthcare and patient-based healthcare that is responsive to the patient's needs and their overall health status, so that patients all get the same wonderful care that's really already available in the US. But we know that that's not true. So, it's how do we deliver this phenomenal care? And if we invest in preventive care and whole person care from the get-go, I think, and I know this is mostly about cancer, but cancer risk, as some have been studying, including some at City of Hope, can start even before pregnancy, right? So your exposures during your life course affects the fetus, affects the outcomes. So if we create healthier communities from very early on, from pre-birth on, we can have better health outcomes for all. So I don't know if that answers, but I know it's going around about, but I really believe in sort of holistic whole person care.
Exactly. Yes. Thank you. And so thank you so much for sharing your expertise and all your wonderful study with us, Dr. Ashing. So thank you for being with us. And thank you to all our speakers this morning. And before we let you go for your lunch break, we just want to thank you for joining today's event. We also invite you to support Cancer Support Community Los Angeles work by making a donation today. So there's a link in the chat that you can click on, and your donations will really help to continue the vital programming our community relies on.